Hello, my name is Deva Sharma. I practice hematology and transfusion medicine at Vanderbilt University Medical Center in Nashville, Tennessee. It's been a true pleasure to work with Terumo on this international Delphi panel to identify the optimal management of pregnant women with sickle cell disease and also to identify gaps in the management of this understudied population. In this study, we used something called the Delphi methodology to obtain expert consensus on several areas of sickle cell disease management during pregnancy. And essentially, the Delphi process represents a method of developing a consensus based on best practice, especially in areas where clinical data are scarce, such as the management of pregnant individuals with sickle cell disease. One thing that did surprise me in our results is the strong consensus that in the absence of contraindications, the experts felt that prophylactic aspirin therapy should be started by 12 weeks of pregnancy and should be stopped at 36 weeks or at labor in the case of early delivery. And this surprised me because, at least in the United States, this is not a universal based practice. But there is strong rationale for this practice based on the higher risk of preeclampsia, eclampsia, and thrombotic events in this patient population. So I think that was an important area of consensus, which really has the potential for further study and to improve the management of pregnant women with sickle cell disease. We highlighted areas of strong consensus for the management of individuals living with sickle cell disease who are pregnant. And these areas of strong consensus should absolutely be disseminated to patients and healthcare professionals. And I think the next step involves close work with advocacy groups to translate these important areas of consensus in patient-centered language so that they can be understood, to educate patients and to really improve the care of this patient population. And we identified multiple areas where there was no strong consensus for the management of pregnant individuals with sickle cell disease as well. And some examples include indications for starting in antimicrobial prophylaxis during pregnancy, knowing that this patient population has a higher risk of urinary tract infection and pneumonia. We also did not achieve consensus on the routine use of prophylactic transfusions in this patient population. So I think that this information is important to disseminate to the medical community through publications and seminars, because these highlight important areas that warrant more funding. And I think important to work with funding agencies to make sure that these critical issues where there was no consensus reached are no longer understudied and are adequately funded. We don't routinely start all these patients on prophylactic aspirin therapy during their pregnancy. So this is an area where I would recommend that we evaluate our practice and strongly consider the implementation of aspirin prophylaxis routinely in this population, knowing that eclampsia, preeclampsia, and thrombotic events represent substantial morbidity in this patient population. I think there were interesting findings about recommendations to discontinue hydroxyurea, ideally 3 months before conception, but also to counsel patients that we don't recommend discontinuation of pregnancy in the case of hydroxyurea exposure. And that's based on very limited data. That's based on data that essentially fails to demonstrate clear teratogenicity in humans. So I think that's an important area where patients are seeking further guidance. And I think there are opportunities to educate further based on the findings in this Delphi panel. I think the single most important finding is the very strong consensus that individuals with sickle cell disease who are pregnant should be followed regularly on a monthly basis, at minimum by obstetrics and gynecology and hematology specialists. And this finding is important because this is a patient population that has typically been underserved by the medical community with, and at least in the United States and other places, this is a patient population which often has limited socioeconomic resources. So it really highlights highlight that our healthcare system and multidisciplinary patient care really needs to meet the needs of individuals living with sickle cell disease during pregnancy to optimize maternal and fetal outcomes. Our Delphi panel identified very interesting areas of consensus and non-consensus when it comes to the application of automated red cell exchange transfusions for the prevention of maternal complications during pregnancy. Interestingly and not unexpectedly, there was strong consensus that for the prevention of frequent acute pain episodes, routine prophylactic transfusions should be used in pregnant individuals with sickle cell disease. However, there were multiple areas where there was not clear consensus among the experts on the panel. For example, there was no consensus that prophylactic transfusions should be used to ameliorate poor fetal outcomes or fetal loss during pregnancy. That's an area that warrants further study, and future studies are warranted that specifically address fetal outcomes in individuals with sickle cell disease. Another area where there was strong consensus is that pregnant individuals with sickle cell disease who've had a prior stroke should have continuation of transfusion therapy during their pregnancy to prevent further stroke. And there was also consensus that women who experience end organ injury unrelated to stroke should also have strong consideration for prophylactic transfusion therapies during pregnancy. And I think this latter finding is important because automated red cell exchanges are highly underutilized in this patient population. So it really identifies opportunities to prevent and manage complications of pregnancy and sickle cell disease that may arise. There were several areas where knowledge gaps were identified among the experts, and the experts did uniformly agree, regardless of country or specialty, that these areas of knowledge gap are important and they warrant rigorous patient-oriented studies to address. For one of the areas that we identified, the routine use of prophylactic transfusions in pregnant individuals with sickle cell disease, the experts did not achieve consensus based on lack of high quality data to suggest that all women with sickle cell disease would benefit from prophylactic transfusions during their pregnancy. However, the experts felt that the risk-benefit ratio of routinely starting prophylactic transfusions in this population should be rigorously studied and should be addressed in the near future. And then some other topics were also identified where there was no strong consensus, including the optimal modality for prophylactic transfusion, and also the optimal timing for starting prophylactic transfusions during or prior to pregnancy. At this point in time, after hydroxyurea or other disease-modifying therapy discontinuation, the experts could not specifically state that a particular time period was optimal to start prophylactic transfusion therapy. In our institution, we often start prophylactic transfusion therapy during the second trimester of pregnancy when acute pain episodes tend to become more frequent. However, this was an area where the experts felt that rigorous hypothesis-driven studies were warranted to address this study and inform healthcare professionals about best practice guidelines based on high quality data. I think that the implications of this study are very profound, especially considering that women with sickle cell disease are understudied by the medical community, particularly when it applies to their reproductive health needs, including pregnancy. One of the key findings in the study was that the experts did achieve strong consensus that poor maternal outcomes during previous pregnancies and end organ injury unrelated to stroke during pregnancy, such as chronic kidney disease or pulmonary hypertension, did warrant serious consideration of prophylactic transfusion therapy during pregnancy. And I think that this finding is significant because transfusion therapies are highly underutilized in this patient population. So it potentially identifies areas unrelated to acute pain, where pregnant women with sickle cell disease may really benefit from the use of prophylactic transfusion therapies to optimize maternal outcomes. So I think that in conclusion, looking at this very exciting international Delphi panel and this process of continued collaboration over the last year, there are a lot of interesting take-home points. This study identified that there's certainly 10,000-foot view questions to answer, such as, should we use prophylactic transfusions routinely in individuals with sickle cell disease? Should we use these transfusions for the prevention of fetal outcomes? And should we identify specific fetal outcomes that should trigger the initiation of prophylactic transfusion? These are 10,000-foot view questions that we identified that need to be addressed. But we also addressed nitty-gritty specific questions, such as, if we perform automated red cell exchanges in this population, what should the target hemoglobin S level be? What should the hematocrit be? What modality of transfusion should we use? Should it be an automated red cell exchange? Should we use simple transfusions? And how do we make this distinction? So regardless of whether it's the 10,000-foot view questions or the nitty-gritty questions, this study really highlighted that a multidisciplinary effort is required to develop and design studies to rigorously address these issues and to provide high-quality data that will ultimately translate to better patient care. Fortunately, this was an international collaborative effort, which identified significant variations in practice and resources within different countries of the experts. And I think moving forward, studies certainly need to be designed in a way that addresses the resource needs of different countries. As we know, most individuals with sickle cell disease reside in West Africa or India, where the resources for medical care may not be similar in other countries such as the United States, the United Kingdom, and France. So consideration of designing studies in these middle to low income countries is important so that there's an equitable and unified approach to the management of individuals with sickle cell disease who are pregnant.